Let's practice a USMLE question. 3-year-old girl brought to the office for intermittent crampy abdominal pain that has been present for 4 months. Initially, pain was associated with loose stools, and over the past month, patient had intermittent painful constipation. Past 3 days, she had flatus but no stool. Her appetite has been decreased, and there is weight loss. The patient has no significant medical history other than episode of coughing and wheezing 6 months ago while she and her family were visiting relatives in Venezuela. Her immunizations are up to date and takes no medication. Temperature is normal. Pulse slightly high 108 and respiratory rate 20. On physical exam, patient is awake but appears tired. Mucous membranes are moist, so no dehydration sign. Lungs are clear to auscultate without wheezing or rales. Abdomen is distended and mildly tender, and there is no rebound regarding, and there is hyperactive bowel sounds. There is no hepatosplenomegaly. The hemoglobin seems normal, platelets normal, leukocytes are normal. Just the thing, eosinophil on the differential count is little higher. uh, and everything else looks normal. Appropriate tests are performed and diagnosis is discussed with the family. Which of the following most accurate statement regarding the prognosis? Let's see the options. A single dose of medication will treat the underlying cause of this condition. B, in most patients, this condition resolves spontaneously without treatment. C, this condition will require surgical correction. D, disease is not curable but it can be controlled by dietary modifications. And E, this is a lifelong condition that may be managed with pancreatic enzyme replacement. So, yes, talking about this case, this child has intermittent abdominal pain and there is eosinophilia and there is evidence of bowel obstruction. How we know there is bowel obstruction? Because there is distension, pain, constipation, and along with that there is hyperactive bowel sounds. So this is, and there is passing of flatus and no vomitus. That means there is some kind of partial obstruction along with eosinophilia. This indicates, and along with this, history of the traveling to the endemic region. This all indicates ascariasis, ascariasis, which is the most common helminth infection worldwide. Ascariasis lumbricoides, which is the organism behind. Ascariasis lumbricoides is an intestinal nematode which is prevalent in the tropical climates. Like other intestinal nematodes such as hookworms, Ascaris larva enters the host and they migrate via venous blood through the lungs and ascends the airway and are swallowed before maturing in the small intestine. Ascaris commonly presents with obstruction either within the lumen of the small intestine or less commonly within the biliary system. The most common presentation is subacute abdominal pain and intermittent obstruction, often mimicking irritable bowel syndrome. However, because adult worms can grow up to 40 centimeters, heavy worm burden sometimes causes complete small bowel obstruction or even perforation, which can lead to emergency surgical interventions. Significant eosinophilia is highly suggestive of parasitic infection. The diagnosis of ascariasis is confirmed by examination of the stool for ova, and not uncommonly when an adult worm, often very large, is shed in the stool. Treatment is achieved with a single dose of albendazole. So just one dose of albendazole is enough to treat this infection. Along with that, supportive care of any associated partial obstruction should be used, for example, intravenous fluid. Reinfection is common in endemic areas or if other family members are also infected and still shedding eggs. So if we look at the option A, that is a single dose of medication which will treat the underlying cause of this condition, is the correct answer, and that medication is albendazole. Along with that, you should give supportive care. If we talk about option B, ascariasis will not resolve without treatment. So this option says in most patients this condition resolves spontaneously without treatment. No, the without treatment, instead this worm burden typically continues to grow until auto-infection of the host with additional eggs, and the auto-infection may lead to very high intestinal concentration of worms, which eventually causes obstruction. If we talk about option C, surgical intervention is indicated for complete obstruction or perforation. So the surgical correction may be required in this case if there was complete obstruction or there is perforation. So this kind of presentation, where there is complete obstruction or perforation, the presentation will be quite severe. The majority of the patient with ascariasis, including this child which we are talking about, can be managed with oral antihelminthic therapy and supportive management, as there is no complete obstruction. Talking about option D, the disease is not curable, it can be controlled by dietary modification. This is correct for the celiac disease. The celiac disease can present with abdominal distension, failure to thrive, and malabsorption. However, this patient has constipation and evidence of bowel obstruction and not malabsorption, and peripheral eosinophilia is very uncommon in case of celiac disease. If we talk about option E, lifelong condition that may be managed with pancreatic enzyme replacement therapy, this is correct for the cystic fibrosis. And cystic fibrosis can present with malabsorption and failure to thrive due to inability to secrete pancreatic enzymes. Oral enzymes can prevent malabsorption. These patients may have abdominal pain and distension, but usually have increased frequency of stools rather than constipation. In addition, eosinophilia is not seen in cystic fibrosis. So to sum up, ascariasis is a common intestinal helminth infection with abdominal pain and signs of obstruction. Presence of eosinophilia is suggestive of helminthic infection, but confirmation requires visualization of eggs or adult worms in the stool. And treatment is single dose of albendazole along with the supportive care. Thank you.